to all, and welcome to today's webinar session. This is part of the Global IPC webinar series. Today's topic is managing COVID-19 exposed and infected healthcare workers. My name is Katie Wilson. I'm an epidemiologist with the International Infection Control Program at the US CDC, and I am helping coordinate this webinar series. A few reminders for everyone as we get started with today's session. First, live translation is available in Arabic, French, Portuguese, Russian, and Spanish. You can access the audio channels by clicking the interpretation button circled here at the bottom of your Zoom window. And a note for everybody that the Arabic translation is available by clicking the button for the German line. Zoom does not have a button for Arabic at the moment, so the Arabic interpretation is on the German line. And we will pause for a second to let the Arabic interpreter say that in Arabic so everyone can hear. All right. Next, if you have any questions about today's session in terms of the topic or any questions for presenters, please use the Q&A function on the bottom of your Zoom screen. If you have any questions about connectivity or recordings or IT issues, please use the chat function at the bottom of the screen. This session is being recorded today, and your attendance is consent to be recorded. The slides from today's session and a link to the video recording will be on the weekly email announcement that comes from Project Echo over the weekend, and additionally will also be posted on the Project Echo and the CDC websites when available. CME, or continuing professional development credit, is available for today's webinar, and that will be available through a link in the chat at the end of the session, which we will share again at the end. So with that, I'm going to stop sharing my screen and introduce today's moderator is Dr. Amber Vasquez, also from the International Infection Control Program here at CDC, and we'll hand over to her to keep the webinar running. Over to you, Amber.
Thanks, Katie. Yeah, as Katie said, I'm Amber Vasquez. I'm an infectious disease doctor and epidemiologist. I work with the International Infection Control Program at the U.S. Centers for Disease Control in Atlanta. And I'll be helping us progress through our webinar today. I want to thank everybody who is joining from around the world. We really appreciate you carving out time to join this webinar. I think there's been a lot of interest expressed to both CDC and WHO in having some expert discussion around management of our critical healthcare worker force that is really just one of the most integral aspects of managing the COVID pandemic. But is also just regularly, putting themselves on the front lines to help us all, get through this pandemic. So, it's very, I think important to everybody who engages in healthcare that we give appropriate attention to healthcare workers. And discuss how we might help manage and preserve that workforce when we have healthcare workers who are exposed or infected with COVID-19. So I would like to go around and have each of the speakers and panelists who will be assisting with our Q&A introduce themselves. So I'll start with our first speaker, who is Giorgio Cometto from WHO. Giorgio, do you want to introduce yourself?
Good morning and good afternoon, everyone. This is Giorgio Cometto. I'm a coordinator in the Health Workforce Department at WHO headquarters in Geneva, and a pleasure to be with you all today.
Thanks, Giorgio. Next, we have our second speaker, which is Dr. Anna Levin from University of Sao Paulo. Dr. Levin, do you want to introduce yourself?
I'm Anna Levin. I'm a professor at the University of Sao Paulo in infectious diseases. My main research interest, my main interest all my life has been infection control. Only recently we've had a lot of outbreaks of tropical diseases, Zika, yellow fever, so I've sort of gone a bit into this area. But basically it's infection control.
Great, thank you so much. Our third speaker, Dr. Mitch Schwaber from the National Center for Infection Control at the Israel Ministry of Health. Dr. Schwaber, you want to introduce yourself?
Thank you very much, Amber. My name is Mitch Schwaber. I'm a native of Boston, Mass. I live in Israel since the 1990s. I'm an internist and infectious disease specialist, and I direct the National Center for Infection Control of Israel's Ministry of Health.
Thanks so much. We'll move on to our two additional panelists who will be joining us primarily for the Q&A session. We'll start with Dr. Maha Talat from the Eastern Mediterranean Office of WHO.
Yeah, good morning, everyone, or good afternoon. I'm very happy to join you in this important webinar. My name is Maha Talat. I'm the regional advisor for IPC at the WHO Eastern Mediterranean Office, and I'm the IPC lead in the IMST committee to respond to COVID-19 for 22 countries in our region. Over to you.
Thank you so much. And last but certainly not least, Dr. Manju Sangar from Tata Memorial Center. Dr. Sangar.
Thank you, Amber. Thank you, everyone. Good afternoon, good morning. For me, it's afternoon. So I'm a medical oncologist by training, and I work in Tata Memorial Hospital, Mumbai, India. Being one of the hotspots in the country, the city is facing a lot of COVID-19, and our center has become a COVID designate hospital for cancer. And I'm involved with the COVID core group for daily decision making and looking after the healthcare workers. Thank you.
Wonderful, thank you so much. So I think then that we will just move directly to our first speaker, and we'll start then with Dr. Giorgio Cometto. You want to take it away?
Thank you, Amber, and good morning and good afternoon again, colleagues. I'll start sharing my screen. The purpose of my presentation is to set the stage for the conversation by providing an introduction to the main policy enablers for health workforce management in the context of the COVID-19 pandemic. And I will articulate policy options in terms of interventions targeting individual health workers, those relating to the organizational environment in which they operate, and system-wide policy reforms and actions. And I have no conflict of interest to disclose. We know that the health workforce plays a central role at all stages of the pandemic response, both in terms of promoting appropriate behavior and hygiene practices in communities, in testing, in contact tracing, referring, case management, as well as provision of mental health support for both patients themselves and their families and communities. I will categorize some of the main policy levers based on a standard framework for health workforce policy management that categorizes interventions according to tools such as, for example, guidelines, financial resources, personal protective equipment in the context of infection prevention and control. In individual factors, and these relate, for example, to the competencies and skills that health workers acquire, but also policies that can ensure the optimization of their roles through appropriate role delegation and task sharing, as well as decent working conditions. Third category relates to the organizational environment. This relates, for example, to ensure appropriate management practices, avoiding overload of existing health workers. For example, this entails creating funded positions to recruit additional health workers, redeploying health workers across levels of care or across geographical regions. And finally, system-wide factors that relate to the broader governance and legal framework. For example, in the current context, this includes regulatory measures to streamline deployment of health workers or to enable temporary or partial licensure to carry out additional tasks beyond the ones that they normally perform, and also includes broader actions relating to health workforce information systems, such as tracking health worker infections. Not to forget, of course, the broader conducive environment, which is maybe slightly outside the healthcare sector per se, but that is equally important in determining the success of uptake and implementation of reform actions within the health sector. So starting from the first, in terms of tools, obviously a key factor is the timely payment of health worker incentives and remuneration. We have plenty of experience on prior outbreaks and epidemics of the high risk of health workers going on strike when there are issues regarding their payment. Beyond that, there are specific considerations to be made regarding the provision of allowances, for example, for sick leave, for disability or death insurance, and these to be applied also to contract workers to avoid, for example, that some health workers have the perverse incentives of showing up at work while ill, because otherwise they would lose their source of income. Among the tools prominent to our conversation today, of course, is the issue of appropriate personal protective equipment as part of broader IPC strategies. And finally, in terms of tools required, having guidance available on the main elements of the response. So from infection prevention and control to clinical case management, mental health support, and risk communication, both with patients and the communities. Other factors that can be targeted at the individual level include optimizing the role of individual health workers through appropriate task sharing policies, for example, envisaging alternative or innovative models for delivery of care using mixed specialists and non-specialist teams, and organizing care delivery pathways accordingly reflecting the local specificity in relation to type of workers and composition of both primary health care and specialized hospital-based teams. Another critical element is the provision of appropriate education and training so that relevant skills that have already been acquired can be refreshed, for example, relating to infection prevention and control, but also the new ones that are required that health workers would not have necessarily acquired before, such as the case management related to COVID-19 patients can be acquired quickly for all the health workers for whom it is relevant. And other aspects that relate to this, but still linked to the optimization of roles and avoiding an overburden of existing health workers, is to identify alternative tasks that can be carried out even by non-health workers, for example, data management, record keeping, and other administrative aspects of that type, as well as in some countries where this is relevant, exploring the role that community health workers and other types of community-based health providers can play in supporting some aspects of the response. In terms of the organizational environment, we know that in some countries and some contexts, the pandemic has posed an exceptional and unprecedented burden on some health services. So in this case, in order to avoid overload, which can quickly result in burnout, poorer quality of care, higher risk of infection of health workers themselves, it is necessary to, it may be necessary to move toward hiring additional health workers. This can be a combination of licensed retirees, unemployed but qualified health workers, in some cases even migrant and refugee health professionals, and health workers who are still undergoing their specialization studies. And obviously partnering with a very wide set of stakeholders from the military to the private sector to faith-based and the non-governmental organizations can be instrumental to greatly expanding this capacity. I already mentioned the importance of ensuring a manageable workload. This can be accomplished through a range of strategies beyond hiring additional health workers. There are measures that have to be considered, including rotating between high intensity and low intensity tasks to prevent burnout, having compulsory breaks, monitoring working hours, and a range of related strategies. Of course, this requires appropriate supervision and management. And in relation, knowing that typically the epidemic will not strike equally across a country or jurisdiction, there may be opportunities to redistribute workers from low to high density areas as well as within facilities. For example, putting temporarily on hold some of the non-essential health services which can be postponed for a limited period of time without compromising too much patient and population health outcomes. And still relating to the decent work agenda, putting in place a number of provisions such as adequate mechanisms for support, such as mental health support, strategies to prevent stigmatization, discrimination, and violence against health workers, and the number of other supportive mechanisms that can be required for the specific context of the pandemic. Finally, we need to reflect also on those interventions that can only be implemented at a system-wide level because they require changes across the health system or across an entire jurisdiction. Examples of what would fall under this category include, for example, the provision of temporary licensure to health professionals that have acquired their credentials in other jurisdictions, for example, refugees and migrants, or within the health workers that have been that are in the process of being licensed, providing accelerated procedures or streamlined procedures for medical and nursing graduates, among other occupational groups. Reforms that can allow pharmacists to take on, even community pharmacists to take on a greater role for early and multi-month refills and implement therapeutic substitution, also to reduce the burden on secondary healthcare facilities and enable both a greater focus on the COVID-19 response, as well as minimize the risk of infection of patients with unrelated conditions that would thus avoid the need to go to crowded healthcare facilities. The provision of practice indemnity for all COVID-19 related health workers, implementing or enacting new policies relating to health worker infection, disability and death, putting in place appropriate return to work protocols. These are typically issues that would apply at the system-wide level, where it's important that there is a uniformity across facilities, irrespective of the actual burden in an individual local context. I've already mentioned the importance of strengthening health information systems for relevant data required for decision support. Critically, in the context of the COVID-19 response, it is important that this adds an element of surveillance and monitoring of health worker infections. And finally, and more broadly, just to underscore the importance of the linkage between the health system and health workers at all levels, including through the provision of appropriate supportive supervision, possibilities of referral, adequate and reliable provision of quality supplies, among other functions. So I would like to conclude here my presentation. In this slide, there are a few key references that have informed this presentation, and happy to take any questions later on. Amber, back to you. Thank you.
Thank you, Dr. Cometto. Appreciate it. And thanks for that great overview. I think that we don't often necessarily think about management of the healthcare workforce from a higher level like that. I think we think of individual healthcare workers and their exposures, but there's a lot of things that individual, institutions and organizations can do to help manage the healthcare workforce on the whole. So I'm going to transition now. We'd actually like to get some feedback from our participants who have joined the call and are viewing this webinar now. We have a few questions where we'd just like to understand a little bit more of what your experience is with healthcare workers and their exposures or infections to COVID-19. So I will start with some polling questions. You should receive a prompt that you can respond, and I'll give a few questions for you, or a few seconds for you to respond. So we'll start with the first question. Has your healthcare facility experienced an outbreak of COVID-19 among healthcare workers? We'll give it about 5 or 10 seconds for you to respond. Great, thanks so much. So let me share the results. Got it. So hopefully you should see those results. Let me know if you can't. But that's actually quite a lot of you have experienced an outbreak among healthcare workers at your facility. So very interesting. Thank you so much. Let's move to the second question. So the second question, has your healthcare facility had difficulty maintaining necessary staffing levels because of too many sick or exposed healthcare workers? Again, we'll give it about another 10 or 15 seconds. Okay, so it looks like also quite a lot, even more than the last questions, or I'm sorry, fewer than the last question, but still quite a lot. So 31% of you responded yes, and 69% of you no. Okay, let's move to the third question. How does your healthcare facility manage healthcare workers who have had an exposure to COVID-19? So this is multiple choice, so please check all of these that apply. I'll read through them and it'll give us a few extra seconds for you guys to click all that might apply, since some of you may do multiple things. So one is perform a risk assessment and decide based on the type of exposure. No risk assessment done and just allow them to work while self-monitoring for their symptoms. No risk assessment done and exclude them from work while self-quarantining at home. Quarantine at the hospital or another designated quarantine facility. Allow them to work while wearing a medical face mask, or none of the above. And I'll give a little extra time on this since I realize it's a longer question and multiple options to choose. Okay, great. So here are the responses. It looks like the majority of you do perform a risk assessment and decide based on the type of exposure how you will manage the healthcare worker. But quite common, and this is actually something that we have heard is a pretty common practice, is to actually quarantine those exposed healthcare workers either at the hospital or at a specific designated facility. Okay, let's move to the last question. So the last question, which of these do you think poses the most risk to healthcare workers at your facility? And again, this will just be picking one, but I'll read through each of these since I know there's a lot of options. Exposure to COVID-19 in the community, not having enough PPE or personal protective equipment when caring for COVID-19 patients, poor IPC practices by the individual healthcare worker, for example, poor hand hygiene, too many patients at the hospital to care for, overcrowding, other sick healthcare workers' lack of access to testing, so you're unable to identify who is infected, or something else that is not listed there. Give it a few more seconds. Great, looks like we've got to a quorum. So the majority of you answered that there's not enough personal protective equipment. And certainly that is a common issue that we found all across the world, including in the US here. While we won't talk specifically about PPE, that we have a future session that will cover a lot of the details of personal protective equipment, we will address this in either the talks or during the Q&A as to how to help manage healthcare workers when they don't have enough access to PPE. But also common responses, exposure in the community, which agree that you're often at greater risk for healthcare workers outside the hospital than inside the hospital. But a concerning number actually concerned about individual IPC practices by healthcare workers, which I think does highlight the concerns that individual provider awareness and education of infection control is also an important aspect of this. So thank you so much. I'm going to, we can close out the polling questions now, and I'm going to share my screen and speak for just a few minutes about some of the technical aspects of the guidance that exists for managing healthcare workers. Give me 1 second, sorry. Okay. Hopefully you can see that. Let me know if you can't. So I'm just gonna touch on not just the guidance, but some operational considerations, especially in situations where there might be limited resources available, and how one might need to make some adjustments to the management based on those access to resources. I have no relevant disclosures. And so our objectives for the next few minutes will be to review some of that guidance, touch on key elements involved with managing exposed healthcare workers, and discuss some of those operational considerations. So the goals of healthcare worker management, and it sounds like based on the polling questions that a lot of you are already doing this to some degree, and so you probably understand some of these goals, is to try to identify healthcare workers who are at risk of developing infection after an exposure to somebody who has COVID-19, either in the facility or outside the facility, and do that as early as possible so that they can be managed for their own safety as well as those who they may have recently been in contact with. Also to reinforce the need for healthcare workers to self-monitor for fever and other symptoms and to avoid coming to work when they are ill. Dr. Comero mentioned that there is a motivation for healthcare workers to come to work for many reasons, even if they are sick when they come to work. And so we want to be able to identify those people and ensure they don't report to the hospital if they are sick. And thereby limit introduction and spread of COVID-19 within the healthcare facilities by those healthcare workers. I won't be able to talk about each of these guidance documents, and these are not all of them that exist out there, but I think for our audience, these are probably the most common technical documents that you may have reviewed or referenced and even used for your own policies at your own facility for managing exposed healthcare workers from the World Health Organization, from PAHO, and from European CDC. So I won't be able to talk about each of these in depth, but there are links at the end to these reference documents if you need them, and you'll have access to those slides after the webinar. But I am going to touch on some common themes in those guidance documents around risk assessment is that it begins with interviewing each of the healthcare workers that has been exposed. And this really can be a very labor-intensive process because you're asking about a lot of different aspects of the potential exposure to determine the risk that they might subsequently develop COVID-19 from that exposure. So that includes asking if this was an exposure in the community or in the healthcare facility. What was the type of interaction? How long did it last? How close were they? Was it involved in direct patient care? And if so, was that when performing an aerosol generating procedure or just in contact with the patient's environment? What type of PPE was the healthcare worker wearing, as well as what PPE was the patient wearing? So aspects of source control that would also affect the potential risk to a healthcare worker who has had an exposure, as well as other IPC aspects such as whether or not appropriate hand hygiene was performed. And then based on those elements of exposure, determining if that was an interaction that is a high risk of potentially developing COVID-19 over the next 14 days or a low risk. And based on that, typically recommending some type of work restriction or monitoring. So for work restriction, for high-risk exposures, so that as an example would be someone who was not wearing appropriate PPE while performing an aerosol generating procedure, like a bronchoscopy or an intubation, those individuals are excluded from work because they are at a higher risk of developing COVID-19. Ideally self-quarantine at home, or what might be more common practice, to quarantine in a specific area of the hospital or at a designated facility, depending on what the policies are in your country. And during that time, actively monitoring for symptoms of COVID-19 for the next 14 days after the date of that exposure. For low-risk exposures, so those that involve maybe partial PPE and just routine patient interactions with someone that they weren't aware was infected of COVID-19 at the time. Those low-risk exposures can involve just self-monitoring of symptoms while continuing to work. And then during that time also reinforcing the importance of IPC fundamentals while you are continuing to work, making sure that physical distancing is still respected, that you're doing respiratory and cough etiquette, hand hygiene, and using PPE. And then aspects of symptom monitoring. For those at high risk, it is active monitoring, where the healthcare facility or a public health authority establishes a regular communication that's either remote or in person to assess them for presence of fever or COVID symptoms. While for self-monitoring among low risk, the healthcare workers really do that themselves and make sure that they check themselves for temperature or for a fever or for symptoms before they report to work and have an individual who they can contact if they develop symptoms. And lastly, I just want to touch on a document that our group at CDC, the International Infection Control Program, has posted to our CDC website. Again, that link will be available in the slides after the webinar. For managing exposed healthcare workers, really operational considerations that take into account the guidance that exists out there from WHO and PAHO and ECDC, but consider some of the challenges with resource limitation. We don't have time to detail all of these now, but I would encourage you to look at that document in addition to the guidance documents earlier in this presentation. That there are unique challenges in limited resource settings where, for example, you may not have enough public health staff to perform the kind of in-depth contact tracing or healthcare worker risk assessments that can be necessary for trying to determine what if an individual healthcare worker had a high risk or a low risk exposure. That type of the type of management that was just outlined that includes things like exclusion from work can sometimes really strain the staff of healthcare facilities, and you may need to adapt from typical recommendations to make sure that critical medical services are maintained at your facility if there are a large number of healthcare workers who have been exposed either to other sick coworkers or to sick patients at the hospital. In some situations, there may be limited testing availability and you have to ration your testing. And certainly we would consider healthcare workers to be a priority group for testing given their risk on the front line and their ability to really propagate or to expand outbreaks in healthcare facilities if healthcare workers are sick, since they interact with multiple patients and multiple coworkers, as well as how to manage some of the challenges that come with widespread community transmission, where healthcare workers are going to be at increased likelihood of bringing COVID-19 into the facility. And there may be measures that are not common that facilities have to implement, assuming that you have some access to resources such as use of medical face masks for all healthcare workers, because there may be lots of exposures out in the community and ongoing risk coming into the facility. And so maybe healthcare workers wear masks at all times if the PPE supply allows, or just indicating that all healthcare workers at the facility need to be monitoring for symptoms on a daily basis. So those are just things that I would encourage you to go and look at, all of these documents that have been referenced in this talk. And thanks so much. I'm actually gonna go ahead and move on to the next speaker. Oh, let me stop sharing my screen. And sorry. We will move on to our third speaker, Dr. Anna Levin from University of Sao Paulo. Dr. Levin, take it away. Oh, Dr. Levin, you're on mute.
So thank you so much for this invitation and for allowing me to be here. I'm going to speak basically about very practical issues, so I think they give room for thought. I have three basic issues to talk about. It's not working. How do I make this move? Ah, okay. So as you know, Brazil now is the main center of the disease at the moment. And this is the number of cases over time. And the state of Sao Paulo, which is a part of the city, which is the southeastern part, is probably the largest state in population. It has 42 million inhabitants. And the greater Sao Paulo has between 20 and 21 million inhabitants. And this is the state which is mostly affected, also because it's the largest population in the country. And these are the main cities of the state of Sao Paulo, and mainly these are the greater Sao Paulo, the larger Sao Paulo, and this is the situation which is an important growth over time. And here we can see this is the state of Sao Paulo, which is affected state in Brazil. So here is the state of São Paulo, and if you look clearly, just at we have a worry about subnotification of cases. So if we look at just the number of deaths by COVID, you can see that the greater São Paulo, the capital and the cities around it, are the most affected. On the other hand, however, if you do the deaths per million inhabitants, then you can see the state of São Paulo is affected all over. And even so, if you work with deaths by severe respiratory syndrome per million inhabitants, then you will see that probably that there's a large subnotification all over, and the state is really affected in the same homogeneous manner. So this is our hospital. This is the largest hospital in Latin America. This is the University of São Paulo Teaching Hospital. It has 2,400 beds. It's tertiary care. It's public. It's non-paying hospital, and it has about 21,000 healthcare workers. And you can see that there are many buildings: children's building, general building, and also the units of the University of São Paulo, the medical school, the nursing school, the public health school. And interesting, we also within the campus we have the state health department, which is very good because there's a very close communication between the university, the hospital, and the health department. So during this epidemic, it was decided that the hospital would be the main center for all the very severe cases of the greater São Paulo. And we separated a building, which is 900 beds, dedicated to COVID, which is this main building. And it has about 7,000 healthcare workers and 300 ICU beds. We've been expanding monthly all the ICUs. So basically, and the patients will be are being referred from other healthcare services, and only the very severe cases are sent to this hospital. So that you can see the number of cases being admitted over time. If this is on the 24th of May. And so it's 50% of the cases admitted to our hospital go into the ICU, and our fatality rate is 25%. As you can see here, these are the patients who have left. So what did we do for the healthcare workers? We have this very large number of healthcare workers, and the majority of them, or the biggest proportion of them, in the COVID building. So the health services decided that if a healthcare worker is symptomatic, doesn't matter what kind of symptoms, they will come to health services. I'll show you health services in a minute. We'll take the PCR and will automatically receive a 3-day leave. So this is quite a stimulant. It stimulates healthcare workers to come, especially if they're tired, because they know that if they have symptoms, they're getting a 3-day leave. If the PCR is positive, their leave is extended until 14 days after the onset of symptoms. If their PCR is negative on the 3rd day, and on their 3rd day of leave, and they have no symptoms, they just go back to work. And if they maintain symptoms despite a negative PCR, they will have leave until they're symptomatic, so they'll be followed up. So this is basically the scheme. And healthcare services is this building here. So this is from March to 26th of May. We've had, just for you to have an idea, we've had 11,000 consultations in healthcare services for various things, including respiratory symptoms. But basically, there were 3,700 tested. And of course, the largest number of tested are in the COVID Institute, and the largest number of positive are in the COVID Institute. 32% of the tested are positive. And just for you to have an idea, we have 7,000 healthcare workers in this institute. So when we have 400 positive in the Heart Institute, that's half the number of the healthcare workers. So really, the perception among the healthcare workers is you're safer if you work in the COVID Institute. And maybe this is a real perception. You're safer if you work in the area where there is COVID and not in the area which is free from COVID. So this is, basically we have at the moment 8% of our workforce positive at some point with a positive PCR for COVID. I think the numbers are huge. It's like a small town, but this is an idea. This is basically the idea. When we looked at the healthcare workers, and this is just an example, this is the Heart Institute. This is supposed to be an institute without COVID. So these are the healthcare workers who give direct care to patients in a non-COVID institute. And if you notice, we have outbreaks. We have outbreaks in the general ward among the healthcare workers, 10 each week. And then we have another outbreak among residents. And then we have another outbreak in a surgical ICU. And so we started to notice that really we are having outbreaks in non-COVID. In a certain way we are, and if you look again at the healthcare workers that do not have direct patient contact, we also have outbreaks. So we've had outbreaks in nutrition, that, you know, and we've had outbreaks in hemodynamics where heart catheterizing is being done, and even in the pharmacy we've had outbreaks. So we started, what we noticed, that we were sort of naive, thinking that we could keep the COVID cases all in the COVID building and we would have all the other buildings working COVID-free. But the fact of the matter is that we have the disease in the community, and we really have to pay attention. And this is happening throughout the other buildings. The second point here, the second issue I want to, is a seroprevalence. So starting this month, especially because the healthcare has really demanded this, we started doing serology for the healthcare workers. So we started with basically the COVID building. We planned to do 6,900 serologies, healthcare workers, and we've done up to the moment 2,000, 2,500. And we have 14% positive. And most of these are not the ones, I mean, there are about 2%, although we've please ask them people who had positive PCR not to come, but a few of them have come because they want to see if they have antibodies. So we have about probably 12%. And this is not different between the ICU, the emergency department, and the hospital ward. So this is another thing. Now, our healthcare workers in the COVID building are very tired by now. I mean, they've been going on for weeks and weeks. And we have a demand to move them around to the non-COVID buildings where there will be probably a lower workload. So now we're probably going to start using results from testing to move around healthcare workers with a bit more freedom. But I think this is subject to discussion. But anyway, this is probably one of the tactics we're going to use. The third issue I want to mention is about a survey. It's a multi-center survey about the perceptions of the healthcare workers about local infection prevention control procedures for COVID. And it's really came up in the Global Research and Innovation Forum done in WHO in Geneva in February. And it was taken over, I mean, in Sao Paulo, as we're very close to the Health State Department, the Health State Department of the state of Sao Paulo decided to launch it in April through all the hospitals through their regional offices. So we have to the moment 2,200 answers. But I'm going to show you preliminary results, a few results of 1,500 healthcare workers at different places in the state. So just to get an idea, this is the state of Sao Paulo again, and this is where the answers come from, about 400 different health services and 92 different municipalities. And the healthcare workers work in a variety of healthcare units, mostly general hospitals, sometimes health 24-hour services and emergencies, and maternity, and a bit in primary care and other areas. So the majority of the people who answered this survey at this first preliminary data were nurses or nurse technicians, and a few doctors and a few of the others. And most of them worked in medical wards and also the emergency and the ICU, but there were a few in surgical wards too. This is what they thought about which protective procedures are currently recommended. So of course, hand washing was 100% recommended. N95 was 92%, disposable gowns 92, disposable gloves 95, full body suits 73%, which is a lot. Isolation of infected patients, eye protection, hand hygiene with alcohol rubs. I'm surprised this is not 100%. And avoiding patient contact was answered by about 60%, which was quite a surprise. Following the infection prevention control recommendations will protect me from becoming ill was a majority. I'm sorry about the colors, but basically the people who agree are the pink here, the blue, and the purple. So most healthcare workers agree that that following infection prevention recommendations will protect them, and asked if they considered that these measures will add unnecessary strain to their workload. The majority answered no, which are these colors, orange, red, and blue. When asked if the healthcare, whoops, I want to go back. How can I go back? I don't know how to go back. How do I go back?
Can you right click and?
Asked if the healthcare service where I work can manage the current demand, the great majority answered yes. And if they will be able to handle the COVID brunt of work for the next 3 months, surprisingly, I'm not even sure this is true, but the majority still answered yes. And if this healthcare service where I work has an effective system for triage of patients, the majority thought yes. And if the healthcare facility where they work is being honest with the staff, and the majority thought yes, agreed. And the healthcare facility where I work would act in the best interest of its staff, the majority said yes. And whether the healthcare worker is concerned about the risk to himself or herself of becoming ill, the majority, and this is the vast majority, said yes. And also the concerns for their family is even larger. The vast majority answered yes. When asked if they're afraid of looking after providing care to patients with COVID, half, I think this is half, many of the healthcare workers answered yes. And if they were to try to avoid contact, and this is what I thought was really shocking, it's quite a few answered that they will try to avoid contact, which is this 19, 12, and 11%. So that's quite a bit of, it's split evenly evenly with the ones who will not try to avoid contact. And the majority will accept that they have a risk of getting COVID as part of their job. But interestingly, they don't feel that they have no control. They have little control. I split evenly. Healthcare workers, part of them thought they had little control, but part of them disagreed that they had little control. It's not like fatalists. Probably they feel they have control over getting infected or not with it. And whether they're looking for another job or thinking about leaving this job because of COVID, the majority answered no. So I think the comments basically are the belief in PPE. They believe in the institutions where they work. They have concerns about becoming ill and about transmitting to family. They fear taking care of patients, and there is a large proportion who believes that they would like to avoid the patients. They accept the risk as part of their job. They believe somewhat in having some control about becoming or not infected, and they do not intend to look out for another job. Now, thinking about this summary, there is, I think, one point. I probably think that it's much more optimistic than we really expected, considering the situation. I think what is worrisome is about the fear and avoidance of patients, and I think this has to be worked. But the belief in, the concerns about becoming ill and about transmitting to family, I think are realistic, and really they probably will help the healthcare worker to avoid getting contaminated. So probably this is not a bad thing. But I think basically, we're open to discussion. This is basically what I have to present. Thank you.
Thank you so much, Dr. Levin. That was great. Yeah, it's great to get some practical experience from someone who's not just in a facility, but also in a facility where there is a rapid increase of cases and the strain that can put on the workforce. I definitely agree that there are a lot of concerning findings from the polling of the healthcare workers about their personal concerns and just how important it is that facilities and organizations and countries try to not just provide healthcare workers with the resources they need, but the reassurances they need. They're undergoing a lot of stress out there. So let's move to our final speaker, Dr. Mitch Schwaber. Mitch, do you want to take it away?
Okay. Are you seeing my slides?
Yes.
Great. Okay. Well, thank you very much, Amber, and thank you for having me. It's an honor to be here. And my topic is the Israeli strategy in protecting the healthcare workforce in the context of the coronavirus outbreak. I have nothing to disclose. Our objectives today are going to be to understand the measures taken by Israel's Ministry of Health to protect healthcare workers from infection by the SARS-CoV-2 virus and prevent exposures that lead to quarantine of healthcare workers, and also to describe the effect of these measures on the incidence of healthcare worker infection and prevalence of healthcare workers in quarantine. So a little bit of background in Israel. We have a population of just approximately 9 million. There is universal healthcare coverage for all citizens. We have approximately 16,000 acute care hospital beds. And our Ministry of Health is the central regulatory health body with jurisdiction over all healthcare institutions in the country. Here's the rough timeline of some of the milestones that unfortunately countries around the world are looking at. Our preparations for the COVID began in January before the first case arrived on our shores. The first travel advisory was issued in January 26th. In January 30th, our progressive sky closings began. The first confirmed case in Israel was on February 21st. And on March 12th, the schools were closed. A national state of emergency was declared by the Prime Minister on March 19th. Our first death was recorded on March 20th. In the first half of April, we underwent partial lockdowns that corresponded with holidays, traditional times to where people move around and gather. But at the end of the Passover holiday, on April 19th, a gradual restart has begun, and that it has increased as the situation has allowed. So as of today, we've had 16,813 total cases and 282 deaths. This is what our epidemic curve looks like. The daily new cases, you can see that we really start to take off in the later part of March and into April before we begin to see a downturn, and that downturn is gradual. This is what the total coronavirus case curves looks like, and really stretching out until the end of May. And I want to focus on this period at the very end of March, where we really start to see a steep upslope in the total coronavirus cases in Israel. So the question is, do we have a brewing crisis on our hands? This is now, I'm going to focus on March 25th. In the general population at this date, the daily number of new infections is increasing, and the number of hospitalized patients with COVID is also increasing. Among healthcare workers, which is the subject of our talk today, there are nearly 2,500 healthcare workers in acute care hospitals who are in quarantine. They're out of work because they're in quarantine. Some of these are infected. Most of them are in quarantine because they've been exposed. Some in the hospital, some outside the hospital. But the daily number of new healthcare worker infections that were definitely or possibly acquired in the acute care hospitals is rising sharply at this point to a peak of 25. And already at this point, there's some evidence that the source of healthcare worker infections was often contact with an infected asymptomatic or minimally symptomatic coworker, and often not the patient that they were caring for. So yes, I would characterize this as a crisis at that point, because just when the Israeli healthcare system needed its workers most, thousands of these workers were sidelined due to infection and exposure. So it's clear that interventions were urgently needed to preserve staff safety and availability. So here is a list of some of the measures taken in healthcare facilities to prevent healthcare worker exposure, divided over the next two slides into different categories. Many of these were taken at the national level, some at the institution level or the institutional type level. The measures involving staffing and workflow, I've listed most of them or all of them here. First of all, a blanket prohibition of overseas travel for healthcare workers, cancellation of elective procedures at acute care hospitals, a thinning of non-essential staff, changing the shift length from 8 to 12 hours and working those 12-hour shifts in what we called capsules. So it was the same workers who worked with each other in each shift and also with the same patient rooms. The two capsules, more than one capsule, wouldn't be exposed to each other. And in the facilities that provided lodging for their healthcare workers, the lodging was also arranged in capsules. There were restrictions placed on outside employment of healthcare workers. Staff dining rooms and on-campus restaurants were for takeaway only, and there was a requirement to eat alone or at the very minimal adhering to distancing guidelines. There was restrictions placed on staff meetings. Whenever possible, they were to take place over Zoom or something like that. Precautions were placed governing the transportation vehicles used to transport workers to and from the hospital or the facility. And as public transportation diminished during the stages of the epidemic, these vehicles took on importance, especially as places where exposures were happening. So guidelines were put into effect to minimize those exposures. There were healthcare worker dress guidelines put into place where either you had to work in uniform, or if the institution didn't have a uniform to provide for you, then you were asked to work in a separate designated clothing of your own that would be taken off at the end of the shift in a safe way. In staff dressing rooms, distancing was implemented. Temperatures and symptoms were monitored prior to each shift, and restrictions were placed on movement of healthcare workers within the institutions. The second broad category of measures implemented were on PPE, personal protective equipment, and mandatory nationwide PPE guidelines have been in place and underwent a few revisions during the course of the outbreak months, but these always included mask, eye protection, gown, and gloves for caring for COVID patients confirmed or suspected, and when an aerosol generating procedure is performed, or even aerosol generation is suspected based on the nature of patient care, an N95 mask is substituted for the surgical mask. Additional measures that were put into place on March 25th, mandatory masking was implemented across the country for all staff, patients, and visitors in healthcare facilities, ambulatory and inpatient. And a second measure of major ramifications were nationwide guidelines for investigating, managing, and reporting exposures among healthcare workers. So from this date forward, there is a standardized tool in place to determine which exposures necessitated healthcare worker quarantine. So when we gathered the data on during these exposure investigations, what we were looking for were data on factors that we knew to influence the risk of contagion. So the proximity to the index patient, the duration of contact with the patient, the use of PPE, was all the required PPE used, or only some of it, or none of it? And when it was it used properly? And the circumstances and intensity of patient contact. Were we just examining the patient? Were we bathing them? Were we resuscitating them? Was there an aerosol generating procedure being performed, etc.? And we could consolidate these investigations into a flowchart with a decision tree to determine whether there was a need for home quarantine for the exposed worker. So the first thing we did was designate the type of exposure. Was there an aerosol generating procedure done? And if so, was the procedure done in the same room at a distance of under 6 meters for more than 5 minutes? Was the healthcare worker doing the aerosol generating procedure wearing full PPE according to guidelines? And if the answer is yes, then quarantine isn't required. But if the answer is no, the next question is, was the healthcare worker wearing a mask? So if the answer is no, then clearly quarantine is required. But if the healthcare worker was wearing a mask, then we would determine the need on an individual basis based on investigation findings. And we would ask the questions of what relating to proximity, to treatment intensity, to treatment duration, and specific elements of that contact that led to the exposure. If there were no aerosol generating procedures performed, then we would ask, was there face-to-face contact less than 1 meter apart for 5 minutes or more? And if not, was the exposed healthcare worker in the same room less than 2 meters apart for 15 minutes or more? If so, was the worker wearing full PPE according to guidelines? And again, if the answer is yes, then quarantine is not required. If the answer is no, then we ask, was the healthcare worker wearing a mask? And if the healthcare worker was not wearing a mask, then we want to know if the patient was wearing a mask. And if the patient was not wearing a mask either, then quarantine was clearly required. But if the patient was wearing a mask, or the healthcare worker was wearing a mask, then again, it doesn't mean automatic quarantine. It means we needed to get more information and then determine on a case-by-case basis whether a quarantine was required. So the upshot of this standardized protocol-driven investigation was that it was no longer necessary to send every exposed healthcare worker home. If our investigation revealed proper use of PPE based on the type of exposure, the exposed healthcare worker could remain on the job. So what are the results of the described measures on acute care hospital healthcare workers? So as far as quarantine, there's been, since March 25th, a steady decline in the number of healthcare workers in acute care hospitals that have required going into quarantine. On March 25th, the peak that we reached was 2,444. By April 30th, that is down 89% to 260. What about new healthcare worker infections that are attributed to a place of work or possibly to the place of work? So for the 7-day period between March 19th and 25th, there were 108 such cases, and that is down 93% by the same 7-day period 1 month later to a total of 8. So in summary, our interventions that were based on implementing safe work habits, universal masking in hospitals, uniform PPE requirements, immediate protocol-directed investigation of every healthcare worker exposure, and a clear definition of exposures that require quarantine have led to a profound reduction in the number of healthcare workers infected and exposed on the job that has preserved the health and availability of the medical workforce. Just prior to conclusion, one image that reflects some of the hope that has emerged amidst all the sorrow. And with that, I will say thank you very much for your attention and turn it back over to you, Amber.
Yeah, thanks so much, Dr. Schwaber. That's great. It is actually a very inspiring side. Thank you for including that final slide, actually. Thank you for your presentation, too. I think it really brings home that while there can be a lot of resources that are necessary for doing healthcare worker exposure investigations, having those elements, having a tool and a flow chart that clearly defines it can be, a lot of work for public health staff who are trying to manage exposed healthcare workers, but can be very useful in helping to protect healthcare workers as well as protect them and keep them on the job, which certainly benefits patients as well. And there was I just also want to point out, since there was also a question in the chat box that came in asking about standardized tools. I should have mentioned this in my talk, but a number of the guidance documents that I referenced in my talk do have some standardized flowcharts or data collection tools to assist with healthcare worker exposure investigations and making determinations about exposure risk. Again, I would encourage you to go and take a look at that and see if those are tools that you could use in your own facility or country and potentially adapt to your specific circumstances. So let's go ahead and transition to the Q&A. I'm going to start with Dr. Talat. And these questions are primarily from those that were submitted during the registration process, but I'll try to include ones where that overlaps with questions that have come in through the chat box. But Dr. Talat, why is it important to learn about IPC as a healthcare worker during this COVID-19 pandemic?
Thank you very much, Amber, for the question. Actually, IPC is a very important discipline that healthcare workers have to learn about all the time and any time, not just during the COVID-19 pandemic. IPC is a very important measure of quality and safety of healthcare services. It protects the patients and the healthcare workers from acquiring healthcare associated infections. It has been always a key strategy for dealing with public health threats of international concern, and this started since the time of the SARS pandemic in 2002, H1N1 response in 2009, the MERS-CoV in 2012, the Ebola in 2014, and of course, the COVID in 2019. I want to say something about the IPC program. I know that the pandemic of the COVID-19 uncovered the huge limitation in implementation of IPC in many low and middle income countries. And I think that we have to use this momentum right now for countries that do not have a really successful and well-coordinated IPC program to start working on that. And we know that we have WHO guidelines describing the core components and the elements of an IPC program at a national level and at the healthcare facility level, to start looking into the elements of these programs and start really implementing this and developing the program. It's taking a long time, requires education, training, guidelines, SOPs, and many other issues. Thank you for the question. I refer back to you.
Thank you, Dr. Talat. We'll just keep things moving. So Dr. Sengar, the next question is for you. Can you talk from a practical standpoint, since this is something you've had to manage at your facility, how have you been sort of safely monitoring healthcare staff for possible COVID, either because they had a known exposure or because they are regularly caring for COVID-19 patients, and sort of what is your practical experience in that?
Sure. Thank you, Amber. Thank you for that question. So what we do at our center, that everyone who's walking into the hospital, be it the staff or the patient or the relatives, they're all screened at the entrance itself with the questions for the symptomatology. And if any one of them answers yes to any of those questions, like any history of fever, cough, shortness of breath, or any member in the family or in the residential area where they're coming from have tested positive, then they are directed to the fever OPD for further screening and testing. So that's something which we do for everyone. In addition, we have made point of contact in the individual departments where these workers, the healthcare workers, can report if they have any of these signs and symptoms, so that early identification and if needed, the isolation can be done after the testing. So these are two important things which we have done. Since in India, we are, and especially in Mumbai, we are seeing a lot of community transmission. So what we have started identifying are the areas, hotspots within the city. If the workers are residing in those areas, then a strict measure is introduced to ensure that they don't report to work if they have any of these symptoms. For some of the areas where the prevalence is really high, we have taken off the healthcare workers from those areas coming to the hospital completely. So these are certain measures which we have placed. In addition, everyone is trained to make sure that even when they are at home, when they are traveling to the hospital or going back to the hospital, they are masked all the time. So just to reduce the risk, they're all trained on IPC, not only in the hospital, but even outside the hospital when they are at home. So these are certain things which we are doing at our center.
Great, thank you so much. Dr. Cometto, the next question is for you. I think Dr. Levin, we got this question, but I think also Dr. Levin's presentation really highlighted the psychological well-being of frontline healthcare workers and how much that is at risk. Can you talk at all about managing the psychological health and well-being of healthcare workers and their family members?
Sure. This is actually a very critical point. Several factors conspire to determine a deterioration of a health worker's mental health, including the high intensity of COVID-19 care, increased volume of clinical services, and sometimes the resulting overburdening of health facilities and workers themselves. High case fatality rates, sometimes tension between public health priorities and patients' wishes, the consequences of dealing with difficult decisions in resource-constrained environments, the overall anxiety in the population, as well as the risk of infection, sometimes compounded by lack of personal protective equipment for health workers themselves and their families. So beyond the holistic approach that I made reference to earlier in relation to an overall appropriate and supportive management environment that reduces overburden, that reduces excessive workload, etc. There are also some specific measures to ensure that health worker mental health be prioritized for both long-term occupational capacity and short-term crisis response. Critical elements include ensuring access to availability and provision of mental health and psychosocial support services for health workers, including suicide prevention through early identification of risk factors. Provision of basic psychosocial support should be available for as a first line care of distress, including, for example, providing at least one trained mental health and psychological support worker in place for every health facility to manage, to early identify and manage priority mental health conditions. Train team leaders in protection of staff from chronic stress, in basic psychosocial skills, supportive and regular monitoring of staff mental well-being. And also finally, at the organizational level, establish relevant approaches to discuss challenges, dilemmas, organize schedules, for example, to include breaks and minimize other work-related stress, and activate peer support mechanisms. And these are some of the interventions that will be more specific to mental health and psychological well-being.
Great, thank you so much, Dr. Comano. Definitely one of the most important, but probably less, least discussed aspects of supporting the healthcare worker workforce. Dr. Schwaber, the next question is for you. You talked, your presentation reviewed sort of the management of healthcare workers and the need for quarantine. And one of the things that your implementation. I'm sorry. I thought I was interrupted. But one of the things that you mentioned was limiting the need to quarantine healthcare workers. But I think there's some concern about healthcare workers who might potentially take COVID-19 back to their home after they have cared for COVID-19 patients or after they have been exposed. Can you talk at all about how you managed those concerns?
Thanks for the question. It's certainly very relevant. I fervently believe that it's the responsibility of the infection prevention practitioners of the world to define and delineate what are the safety measures that will enable frontline healthcare workers to care for patients with any infectious disease, whether that's AIDS or TB or multi-drug resistant bacteria or COVID-19. We have to gather the data and we have to define what equipment is needed and how to properly use that equipment and conduct oneself in order to treat the patients who require our care, but at the same time not put ourselves in jeopardy and our families in jeopardy when we go home. So I think that even though we're dealing with a new virus and it's a learning, we're learning it as we go along, quite a lot of data have already been gathered that really do demonstrate how healthcare workers can protect themselves, what PPE are required for various scenarios of care, whether there's no risk, low risk, minimal risk, high risk, and what the type of procedure is, whether it's a patient who is, whether you're doing an aerosol generating procedure or not. There are different stratifications of what equipment you need to use and how to conduct yourself. And these work. I'm confident to say that these work. But it's our responsibility as the infection practitioners to give the instruction on how to use them. And it's the responsibility of the medical administrators and governments to make sure that there are adequate supplies available for healthcare workers to use when they're on the front lines. I'm aware by reading the press of what's going on in the world and healthcare workers who decide that they feel a responsibility to keep themselves separated from their families because they believe that they're in danger and they're putting their families in danger. I am sad when I read these stories. I think that that is a failure of the system, and I think that that failure should be addressed everywhere where COVID-19 is being treated. Thank you.
Thanks so much. I'm going to skip around a little bit on the questions just because I think there is another question that was asked that probably is a good follow-up to this. There's and I think we'll throw this one back to Dr. Talat. obviously PPE, good quality PPE and availability of it is essential for helping to protect healthcare workers, but there are many facilities that are struggling with sufficient PPE supply. Dr. Talat, can you talk a little bit about healthcare workers trying to protect themselves and some of the issues that are that you have to deal with when you don't have complete PPE?
Yeah, Amber, thank you for the question. I know that PPEs were really very important tools to protect healthcare workers. And for the COVID response, and again, particularly in low middle income countries, where IPC is not a well-developed discipline, IPC was just restricted to PPE use, which is the most visible intervention. And even in the initial phases of the pandemic, everyone was putting on full attire PPE, even when not recommended. But we have also to recognize that IPC is not just about PPEs, but it's more, again, about administrative and environmental controls. For example, having full-time IPC teams in hospitals, well-trained teams and staff, IPC policies, procedures, infrastructure, environmental cleaning, hand hygiene, waste management, many items related to the IPC. Now comes to the question, what to do when we don't have enough PPE. There was a WHO guidance that actually put some of the options on what to do if healthcare workers or healthcare facilities do not have enough PPE, and they listed some of the options. For example, if feasible, you can use some telemedicine or telephone hotlines to start evaluating the suspected cases of the COVID. You can use physical barriers, like, for example, glass or plastic windows, in case, particularly for the triage and the screening areas. You can postpone some of the elective non-urgent procedures and hospitalizations to redistribute the PPEs just for the care of the COVID patients. For the confirmed COVID patients, you can cohort them those without co-infections, in order to streamline the workflow and facilitate the extended use of the PPEs. Of course, we all know that we can designate some dedicated healthcare workers for COVID patient care so that they can again use the PPEs for longer periods of time, restrict the number of healthcare workers from entering the rooms of the COVID patients if they are not involved in providing direct care, and so on. And I'm sure that hospitals had to go through some of these strategies because they had really, in some point of time, shortage of the PPEs. Thank you, and over to you.
Thanks so much. Yeah, I'd like to focus on some questions that were submitted about testing and returning healthcare workers to work after they've been infected. And this is commonly showing up on the chat box. So we'll focus the next couple of questions on that. I think we'll start, maybe we can get feedback from both Dr. Senger and Dr. Levin on this. Dr. Senger, we'll start with you. How have you been making decisions about how to return previously infected healthcare workers to work? Are you doing that based on symptoms or testing? And I would be very interested to also hear your specific considerations, given that you work at a hospital that has a very vulnerable cancer population, and are there special considerations for returning previously infected healthcare workers to work when they care for those kinds of vulnerable populations?
Thank you, Amber. That's really relevant, and things are moving and changing very quickly. How you will allow a healthcare worker, whether it should be a symptom-based strategy or a test-based strategy. We have been lucky that we have an in-house testing facility available within the center as opposed to other centers in the country. And the reason why we chose the test-based strategy, because we are treating the patients with malignancy. These are immunosuppressed, immunocompromised patients. So we want to be extremely careful to ensure that nobody is shedding an active virus when they walk in back to the work. So that's the reason why we are looking at the test-based strategy. What we do is look at the symptom disappearance, and then at around day 14, we do the test. And if one test is negative, we repeat another RT-PCR after 24 hours. And if both these tests are negative, we suggest these healthcare workers to remain in home isolation and join back after 2 weeks. So we are being extra cautious here because the kind of population we are handling, it's difficult. So this is what our strategy is. Things become a little more tricky when you're talking about asymptomatic healthcare worker who are, who test positive because they were quarantined because of exposure earlier. And then, when you test them, which we do normally at around day 12 or day 13 of their quarantine, and if they turn out positive. So they don't have symptoms. So that in those individuals, we take the date of testing as date of diagnosis or possible exposure. And then again, we repeat the test 14 days later. And if there are 2 consecutive 24 hours tests negative on RT-PCR, we allow them to join back. So this is what we are doing. We are reviewing our strategy because, with lockdown, it was very difficult to, have many more quarantine and many more, positive individuals remaining away from work for close to a month. So we are reviewing our strategy. And as a test strategy, we have started, saying that we'll call them back on day 21, meaning 14 days they are negative, and then we call them 1 week later. We retest them and see whether they, anyone has started reshedding the virus or it's all dead elements. So that's a gray area, but that's where we are, looking at, just to make sure that we have enough people to work in the hospital at the same time, not to compromise the safety of patients.
Yeah, that's a great point, needing to balance both those things. Dr. Levin, is there anything you'd like to add? Are you using the test-based or a symptom-based strategy for returning healthcare workers back to the workforce after they've been infected?
No, we're using 14 days after of course, the patient, the healthcare worker has to be asymptomatic for 72 hours. And 14 days of symptoms. Basically, we're not using the test. But for transfer of patients, supposing the COVID patient has a cancer and he's in the COVID institute and he has to go for chemotherapy in the cancer institute as soon as he's better, right? So then we test the patient for transfer if he was PCR positive at first. Sounds a bit, yeah, basically that's it.
Got it. Thank you so much. I also wanted to see, Dr. Levin, if you talked a lot about seroprevalence testing, and I'm also wondering if you have explored or considered the idea of regularly testing healthcare workers, not for seroprevalence, but with a PCR diagnostic test, almost as a way of regularly screening. I think this is questions that have come up in the chat box as well as during registration, wondering if basically regular testing screening of healthcare workers is something you've considered. And Dr. Schwaber, would love to have your thoughts on this after Dr. Levin as well.
Well, we didn't think about that, basically. We thought if you start testing with PCR, what intervals do you intend to use? And we have noticed, at least with patients who are definitely infected with COVID, that very often their PCR is negative. So we were not sure exactly what the sensitivity and specificity of the test is that we should, and what are the intervals we should work with for testing all these patients. And I think the worst of all is if we just do not have the resources to do that. So, I mean, this is not something we decided that we can invest. This is I don't know, it's a poor hospital, basically. This is the sort of thing we decided we do not want to invest in.
Gotcha. Dr. Schwaber, is there anything that you would add about your maybe considerations of this in Israel? Oh, you're on mute.
Sorry about that. It's hard to come up with a one-size-fit-all approach to healthcare worker testing because it really depends on what's going on in the background. First of all, how much a community spread there is of the virus, and also what's going on in the healthcare facility. Is there adequate PPE, and is there good compliance with PPE? I think it's good to have an idea and to do at least some baseline testing to know whether you have a problem or not if you're not getting that information from outside. in certain circumstances, for example, in our long-term care facilities, which are known around the world to be danger zones when you have geriatric populations, and the virus can spread like wildfire among residents there and also among staff. So we have a more aggressive approach at the national level to testing healthcare workers there. And when a case is discovered, either among a resident or among staff, then we test everybody and quarantine those who are positive.
Got it. Yeah, great points from both. That it really depends on the circumstance, and there is no one size fits all. I think that was a great way to put it. So we're at time, and so I want to thank all of our panelists, and I want to make sure we end on time and respect all of our speakers and our panelists at time, as well as our participants. And so Katie, I will turn it over to you to do a quick wrap up.
Yes, thank you, Amber, and thank you to all of our speakers and panelists today for the great talks and presentations. Quickly for announcements, as mentioned, to receive CME credit, Amy from Project ECHO posted in the chat box the links in each of the languages to complete the CME survey. So if you would like CME credit, please click on those links. Thank you for all the questions and answers today. We were able to answer some in the Q&A box and some live. And if you have any additional follow-up, can email after the session. And please join us next week, Thursday, June 4th, when we will talk about WASH in healthcare settings, water, sanitation, and hygiene in the context of COVID-19. And we're looking forward to that discussion. So again, thanks to all the speakers and panelists and to Project ECHO for facilitating this webinar series for us, and to all the participants today. And thank you so much and have a good day. Goodbye, everyone.
Thank you, everyone.
Bye-bye.
Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you.